Good morning or afternoon or evening, wherever you may be in the world. This is Adriana from Texas Tech University Health Sciences Center El Paso in El Paso, Texas, and I'm coming to you from the Georgia World Congress Center, where this year's American College of Cardiology's 70th annual scientific session was originally going to take place. I worked on this case in collaboration with Dr. Rocky Makija, Dr. Clifton Espinosa, Dr. Kazuyo Kajima, Dr. Ahmed Ibrahim, and Dr. Chandra Oja. And now, on behalf of my team, it is my privilege to be virtually presenting complex clinical case entitled Takotsubo Cardiomyopathy and Refractory Shock Exacerbated by Left Ventricular Outflow Tract Obstruction. You may scan the QR code on the bottom right-hand corner to view our poster. The authors nor I have any disclosures relevant to this talk. Takotsubo cardiomyopathy, also known as stress-induced cardiomyopathy, has become a common entity in clinical practice. Identifying unique complications associated with this, along with appropriate management strategies, is of utmost importance. We present a case of an 80-year-old woman with no significant past medical history. She presented with left hip fracture after sustaining a mechanical fall. She underwent intramedullary nailing without post-operative complications. On day 2, she had sudden onset of dyspnea and orthopnea. Her vitals were mildly unstable. She was tachycardic in the 130s. Her blood pressure was soft around 105/70 millimeters of mercury. She had labored breathing with mild desaturation around 90 to 92% on room air, and the chest x-ray showed mild pulmonary edema. The 12-lead EKG showed ST segment elevation in the anterior leads, as shown here. Troponin level was 1.4, BNP around 40,000. And the cath lab was then activated, and she was taken for an urgent angiogram, which was unremarkable. As seen both of these projections, there was no significant coronary artery disease. Transthoracic Echocardiogram, as shown here, demonstrated apical ballooning with hypercontractile basal segments and proximal septal thickening. The initial gradient we measured across the left ventricular outflow tract was 5.7 millimeters of mercury with a corresponding peak velocity of 1.2 meters per second. We also performed a CT angiography of the chest after the cath, which did not show pulmonary embolism, and she was conservatively managed. The following day, she became increasingly hypotensive with a systolic pressure of 70, tachycardic, and complaint of abdominal pain. Lactic acid then became elevated at 8.9 millimoles per liter, and the surgery team then became suspicious for ischemic bowel. So they took her to an emergent exploratory laparotomy, which was unremarkable. However, the patient continued to be hypotensive despite initiation of empiric antibiotics and usual first-line vasopressors that are norepinephrine, vasopressin, and dopamine. We were suspicious for LV outflow obstruction, so overnight, the cardiology fellow performed an urgent repeat echocardiogram, which showed significant dynamic LV outflow obstruction, with an increase in peak velocity across the LVOT from 1.2 meters per second to 3.4 meters per second, with a corresponding elevation in peak pressure gradient from 5.7 millimeters of mercury to 46.2 millimeters of mercury. We then switched the vasopressors to phenylephrine only and added a low dose of intravenous metoprolol. This led to massive improvement in hemodynamics and eventual resolution of shock. Our patient did very well a few days later and was discharged to a rehabilitation facility for recovery. So our learning points from this case highlights, number 1, the importance of recognizing dynamic left ventricular outflow obstruction in the case of Takotsubo cardiomyopathy. This is known to occur in about 15 to 25% of patients, with Takotsubo cardiomyopathy due to hyperdynamic basal segments of left ventricle and hypokinetic apical, as well as mid-ventricular segments. Number 2, vasopressor agents of choice, in this case, phenylephrine, which is an alpha-1 agonist, increases afterload and therefore reduces intraventricular gradient. Also, the use of diuretics should be used very cautiously, as the gradient across the valve may exacerbate. And finally, number 3, when you do suspect this, obtaining a repeat echocardiogram is helpful to clinch the diagnosis. Here are our references. And we appreciate you taking the time to listen to our presentation. If there are any questions, please direct them to myself or Dr. Chandra Oja. Thank you, and I hope that you all stay safe and hope to see you at next year's scientific sessions in Washington.